Hey everyone, welcome back to Nurse Crit. My name is Jason. I'm an acute care nurse practitioner. Let's talk about something basic today. How well do you know your oxygen delivery systems? Please don't click away. I promise you will still learn at least one thing you didn't know or realize before. The objective for this video is to help you understand the various oxygen delivery devices and when one might be preferred over another. We will review the nasal cannula, simple mask, Venturi mask, non-rebreather mask, and also our non-invasive modalities like high-flow nasal cannula and BiPAP. I will not discuss mechanical ventilation in this video because that is a topic that can take up a whole video by itself. Heck, we have an entire profession dedicated to managing ventilators. So yeah, not today. Oxygen is one of the most common interventions we use on patients in the hospital. It's essentially free. I know technically nothing is free, but you get what I mean, and is readily available in every room in the hospital. We use it whenever patients are not oxygenating adequately on room air. No matter what unit you work in, whether it's med-surg or ICU, ensure you have at least one oxygen flow meter connected to the wall, ready for immediate use. Even in resource-limited hospitals, you gotta have oxygen readily available for any kind of emergency. A few other reminders before I review the individual devices. The FDA classifies oxygen as a drug and therefore requires a physician order. Obviously, in the real world, we don't wait for an order. We apply it first to stabilize the patient, then we can get the order later. Please do not be one of those nurses who lets bureaucracy kill their patient. I guarantee it won't go over well when a court asks you what happened to your patient and your response is, well, I didn't have an order to apply any oxygen. When we administer oxygen, understand it's delivered in various concentrations. This is known as the fraction of inspired oxygen, or FiO2. The room air that we breathe has an FiO2 of 21%. Unless you are trapped in an airtight space, you theoretically will never breathe in less than 21% oxygen. You might be thinking, well, what about in the mountains where it's hard to breathe? Actually, the air in the mountains still has 21% oxygen. The reason it's harder to oxygenate in high altitude has to do with the atmospheric pressure being less than at sea level. The last important point to remember when administering oxygen is to use the lowest amount necessary to maintain adequate oxygenation. You should actively be trying to titrate down oxygen levels on a ventilator or non-invasive machines or even on a nasal cannula. Oxygen is considered a drug because excess amounts are toxic to the body. We can't live without it, and we can't live if we get too much of it. Think about it. In nature, we have no way of inhaling more than 21% FiO2. Concentrated oxygen is a man-made product. One of the practice pearls I teach nurses is that your patient should never have a pulse ox of 100% while on supplemental oxygen. If they sat 100% on room air, that's fine. But once you place them on oxygen, 99% is now your maximum target. I know 100% makes us feel good inside, but you may actually be causing harm to your patient. The first oxygen delivery device to discuss is the nasal cannula. I didn't bother to look up any statistics for this claim, but my life experience tells me this is by far the most common device used in practice. It's a plastic tube with two nasal prongs that are placed in the patient's nose. Of note, the prongs are usually curved, and the curvature should point downward. It's very common for new nurses to apply it pointing upward. When using the nasal cannula, we prescribe it in liters per minute. On your flow meter, make sure the line marking intersects the middle of the floating ball. For a standard nasal cannula, we can run anywhere from 1 to 6 liters per minute of oxygen through it. Here is a table of the approximate FiO2 a patient is receiving based on the flow rate. Each liter per minute is approximately 4% additional oxygen. I saw a table like this when I was a new nurse, and my stupid self thought that for some reason the oxygen coming out of the wall increased as I turned up the dial. I didn't understand that the oxygen coming out of the wall is pure 100% oxygen. The reason it only delivers 24 to 44% of supplemental oxygen is because of entrainment. This means the oxygen we're giving is mixing with a lot of room air that's getting sucked in around the prongs, which dilutes it. The nasal cannula, therefore, is super variable in the amount of oxygen it delivers. The size of the patient, the diameter of the nares, the respiratory rate, if the patient is mouth breathing, can all affect how much oxygen is actually delivered. Understand that a nasal cannula works by filling up the nasopharynx with oxygen between breaths. This acts as a small anatomical reservoir, so when the patient takes their next breath, it's a more oxygen-rich air. And that's also why we don't turn the nasal cannula up higher than 6 liters. 6 liters per minute is generally enough to fill up the entire anatomical reservoir, and anything beyond that is just blown back out the nose around the cannula. We generally recommend adding a humidification device to any nasal cannula flowing at 4 or more liters per minute, but I personally have added a humidifier for even 2 liters, just to be nice to my patients. Another pearl I like to teach nurses is although we traditionally say that 6 liters is the maximum you can put through a nasal cannula, you can and should exceed this limit in a crashing patient. Don't hesitate to crank it up to 15 or even 20 liters per minute in an acutely decompensating patient while somebody goes to obtain a non-rebreather mask. As I will talk about later with high-flow nasal cannula, those run at 20 to even 60 liters per minute. So 15 liters is relatively low compared to that. If you happen to be an MCRIT member, you will know that Dr. Scott Weingart talks about this extensively and even recommends, with evidence, that you should actually be using the nasal cannula at 15 liters or higher before and all throughout any intubation attempt. Like I said before, don't let the so-called rules get in the way of saving your patient's life. I assure you, from personal experience, that cranking up a standard nasal cannula does not cause the patient's head to explode. In fact, this pearl might be the most important takeaway today that will help you save a life. The next oxygen delivery device is the simple face mask. Because it kind of cups the patient's face, it creates an additional reservoir beyond just the nasopharynx for oxygen to accumulate between breaths. This device requires flow rates of at least 5 liters per minute and can go up to about 12 liters per minute. This is capable of delivering approximately 30 to 60% FiO2. The most important thing to remember about the simple mask is that you must not let the flow rate go below 5 liters per minute, or else the patient will be able to rebreathe their carbon dioxide. It needs that minimum amount of flow to flush out the mask after each exhalation. Failure to recognize this may result in hypoxemia despite you actually giving oxygen. In my experience, the simple mask isn't used all that much, probably mostly used in the recovery room, maybe the emergency department. For most other hospital units, the nasal cannula is sufficient, and if it's not, we often move on to non-invasive or even mechanical ventilation. The next delivery device to cover is the Venturi Mask. I would say this one is used the least, and I maybe have seen it a dozen times over a decade. The advantage of the Venturi mask is that it can deliver a more precise FiO2 than the other masks or cannula. Because I see this so infrequently, I'm not very well versed in its technical specifications. Basically, it has a dial in which you can regulate a specific amount of FiO2 delivered to the patient. It lists how many liters to turn up the flow meter to, and then you adjust the opening to allow a set amount of room air to get entrained. This allows for specific mixing and therefore a more precise FiO2 delivery. The Venturi mask is most commonly used in hypoxemic patients with COPD, for whom excess oxygen could depress their respiratory drive. The last type of oxygen mask I will discuss is the non-rebreather mask. By the same principle as the nasal cannula and simple mask, the non-rebreather mask has an even bigger reservoir, an entire 1-liter bag, where oxygen can accumulate and concentrate. The idea here is that with a full reservoir bag, you are inhaling almost pure oxygen without entraining any room air. And one-way valves prevent rebreathing any CO2. In order to achieve this, you must crank up the oxygen flow rate to at least 15 liters per minute, but may require more depending on how fast and how deep the patient is breathing. This mask only works if you keep the reservoir bag from deflating no more than half of the volume with each breath. This may require you to put the flow rate at 20 liters or more. For me, in an emergency, I just put it to flush rate, which is basically as far open as the dial will turn. That way I don't have to worry about it anymore. You may have heard that a non-rebreather mask delivers 100% oxygen. However, in reality, a non-rebreather mask can only deliver about 60 to 90% FiO2. For those of you who are astute observers, you may have realized that a true non-rebreather mask doesn't really exist as far as I've seen. Virtually all non-rebreather masks only have a single one-way valve instead of two. This is by design for safety reasons. Let's say the tubing accidentally disconnects from the oxygen source or the reservoir bag gets twisted so that no oxygen was entering the mask anymore. If you had two one-way exhalation valves on the sides, the patient would suffocate. They could blow air out, but would not be able to inspire any air in. I think this is an insanely unlikely scenario, but the fact that it exists probably means someone somewhere in this world has died this way. But that's just supposition. So because of this safety measure, non-rebreather masks are in essence only a partial rebreather mask. It can't be a true non-rebreather without the two one-way exhalation valves. Okay, now we can move on to the non-invasive oxygen systems. The first one is the high-flow nasal cannula. Like I briefly mentioned earlier, this is also a special nasal cannula that delivers heated and humidified oxygen at flow rates of 20 to 60 liters per minute. It also uses a blender to adjust the FiO2 to a specific target. Some of the benefits of using high-flow nasal cannula are that it's a little more comfortable and better tolerated than BiPAP. Also, has less chance of facial pressure ulcers than BiPAP. It provides positive airway pressure and a low level of PEEP. Patients can still communicate and eat and drink without disruption in therapy, and it can reduce the need for intubation and mechanical ventilation. There are two main settings you need to know as a nurse. They are the flow rate and the FiO2. For patients in hypoxemic respiratory failure, you will titrate the flow rate to the respiratory effort. You can start at 20 liters per minute and increase it until the patient's work of breathing improves. Initially, you will probably have the FiO2 at 100%. Once you have established the necessary flow rate, you can gradually wean down the FiO2 until you reach your minimum SpO2 target. Finally, I will talk about non-invasive ventilation, sometimes called BiPAP. It's not that important, but for trivia purposes, BiPAP is actually a trademark term for specific machines manufactured by Philips. So if you're a stickler for those kind of nuances, then you actually should refer to it as BPAP and not BiPAP. Anyway, getting back to the important stuff, non-invasive ventilation, or NIV from this point forward, is a modality that applies a tightly fitting face mask and uses bi-level pressure to augment respirations. The patient must still be breathing spontaneously, otherwise they should just be intubated. When the patient initiates a breath, the machine detects this and then immediately blows in air at the prescribed inspiratory pressure. As the patient exhales, the machine maintains a certain amount of end expiratory pressure to keep the alveoli from collapsing. As a nurse, the primary NIV settings you need to know are the IPAP, EPAP, and FiO2. The IPAP is the inspiratory positive airway pressure. Typically, this starts around 10 to 12 centimeters of water, and it can go as high as 30 centimeters of water. Similar to high-flow nasal cannula, the IPAP can be titrated to the patient's work of breathing. but we most often titrate it to correct an abnormal PCO2. The EPAP, or expiratory positive airway pressure, is equivalent to the PEEP on a mechanical ventilator. If we want to lower the FiO2 to avoid oxygen toxicity, we can increase the EPAP to improve the patient's oxygenation. So in a nutshell, if you want to fix the PCO2, you adjust the IPAP. If you want to fix the PO2, you adjust the EPAP and the FiO2. NIV can be used to reduce intubations, however, it is not a substitute. If you have a patient that is clearly headed down the path of intubation, you don't bother with the non-invasive modalities. These are more for moderate level respiratory failure in patients who need a little extra help. If it's evident they will need us to completely take over their respiratory function, go right to intubation. When using NIV, the main drawbacks are that the patient cannot eat, it's very difficult to speak through the mask, and there is a decent risk for facial pressure injuries. It can also be uncomfortable, which decreases the patient's compliance. But when compared to high-flow nasal cannula, the NIV tends to be more effective at oxygenating as well as clearing carbon dioxide for patients in hypercapnic respiratory failure. The last pearl to offer you guys is to always notify the provider if your patient is having increasing oxygen requirements. This is always an ominous sign that requires further investigation. If you go from 2 liters nasal cannula to 4, maybe that's tolerable. But once you start going higher than that, the doctor needs to know. Similarly, if a patient on a non-invasive or even a mechanical ventilator is receiving 50% FiO2 but starts needing more and more FiO2 just to maintain a saturation, that warrants an immediate call. Never sit on a patient that is requiring more oxygen. I hope you have a better understanding of oxygen delivery devices. Although it might seem a bit basic, it was a good refresher, even for me, for things I don't really think about on a regular basis. Please share this video with your nursing friends and consider subscribing to my channel if you haven't already done so. Thank you all for watching and see you next time.